Thank you, sir, for your wonderful presentation. Now the next topic is choosing the right implant. The presenter was Dr. SIMA, but unfortunately she could not make it today. So it is very important to understand what kind of implant we want to put in enucleation and evisceration. So the purpose of this orbital implant is to replace the lost orbital volume, to give as good a cosmesis as possible to match the other eye, to eliminate problems like superior sulcus deformity and inophthalmos, and also to maximize the process's motility. So when you look at the evolution of orbital implants, we've got these mules implanted hollow glass spheres which are no longer in use. Then we have got the biointegrable implants and the expandable implants. The ideal orbital implant should be one which will restore the orbital volume completely. It allows motility of the processes. There is no exposure or migration. And in children, it should stimulate the orbital growth. So there are three questions which come into mind. What should we implant? What material? What size should we implant? And where should we implant? Now, what to implant? So the most common material that we use are the PMMA and the acrylic. Now these two materials are very inert. They are smooth. They are non-porous. Implantation is easy. There are different sizes, and the biggest advantage is there is reduced infection and therefore reduced chance of extrusion of the implant. So PMMA is still the most widely used implant in India, and it is very, very popular among all the oculoplasty surgeons. The drawbacks you may occasionally have is of implant exposure, but that is when we have a very tight closure which we have done, and implant migration can happen because the implant will slowly start to migrate downwards because it's a very smooth implant. Now motility can be achieved if we can do a myoconjunctival technique of enucleation, where the implant is actually attached to the fornices through the muscles, and therefore the movements of the implant will be transmitted to the processes. So when the lateral rectus contracts, the eye will move outwards, and when the medial rectus contracts, the eye will move inwards. Now pegging is not usually planned in children, and implantation in children is very difficult using a pegging, and also affordability is a big problem, and hence PMMA still becomes the best choice of an implant. So that is about the non-integrated implants. Now let's talk a little bit about the biointegrated implants. Now the biointegrated implants are the ones in which the vascularization is going to happen inside the tissue, and because of this there will be better movement of the implant. But the only way you can actually improve the motility is by doing a pegging. Now what is pegging? Pegging is placing a small peg in front of the implant to which this process is very firmly attached. So there are two materials which can be used for this biointegrated implants: the porous polyethylene and the hydroxyapatite. Now hydroxyapatite, which is usually coming from the is difficult to insert, and we have a difficulty in attaching the extraocular muscles because it's very brittle. If you have ever used it, it can actually crack many a times. It has also got a very rough surface, and it will cause a drag on the tenons and the conjunctiva. So we need to ideally wrap it up in different materials like sclera or fascia lata or a vicryl mesh. So this is how we wrap the implant in donor sclera, and then we have made these small cuts to implant the extraocular muscles, the medial superior and the inferior and the lateral rectus, or we can make a small vicryl mesh which is wrapped all around the implant, and to this the muscles can be attached. Porous polyethylene is slightly better than hydroxyapatite. It allows fibrovascular ingrowth. It is smoother than hydroxyapatite, and therefore it is easier to implant. There is no need of wrapping materials, and the extraocular muscles can be attached directly through the implant. The cost is also very low, and there are various shapes which can be available. So we have different shapes with these grooves for the extraocular muscles which can be used, or small markings for the extraocular muscle attachments. But again, one of the problems that we face in these biointegrated implants is the problem of high cost, the high risk of exposure, and the high risk of infection. So unless you do a pegging, that is, you actually make a hole in the implant, put a screw, and then attach the process to it, there's no added advantage over a PMMA implant. Again, problems like discharge, extrusion, and pyogenic granuloma can occur with these special the hydroxyapatite and the porous polyethylene implants, and therefore PMMA still remains the most common kind of implant. Now these were the autologous implants. Now let's talk about the dermis fat grafts, which is which comes from the body itself. So here what we use is the dermis and the fat underneath. So we remove the epidermis by injecting usually some local anesthetic, creating a purity orange appearance and removing the superficial epidermis, and we just use the dermis and the fat. Now the advantage is that this is a living implant, and we can use it both as a primary implant, or we can use it as a secondary implant, especially in case of children. So when should we use a dermis fat graft? So in a child who has got both volume and surface loss, we can use a dermis fat graft. If there are failed multiple socket surgeries, we can use a dermis fat graft, or if it's a very difficult socket or a post-enucleation socket syndrome where you want to possibly give a lot of fat here on the top, you can use a dermis fat graft. Or a chronically exposed implant can be covered by a dermis fat graft because that is going to vascularize very fast and it is going to heal very well. Or post-trauma, there is a chemical injury, we can definitely use a dermis fat graft. Or congenital anophthalmos, we can also use this. One of the other options is to use a hydrogel socket expander. So this is a hydrogel socket expander. This is usually for the socket, and there is a separate one for the orbit as well. And these we suture inside the socket between the two lids, and this can be used to expand. So when we put water on hydrogel, then it's going to expand in size, and therefore it will expand the orbit and assume a large size. So that is about what material to implant. And next is what size to implant. So if you use an undersized implant, you will have a smaller eye or a deep superior sulcus, which is this deformity. So it's a deep superior sulcus on the top, which you see. So once you put an undersized implant, this problem is going to happen, and you can always not have a very large processes. So there are different types of rules which we follow about the size of the implant. So the implant should be at least 70 to 80% of the volume of the orbit, which is actually very difficult to achieve in real life. And the process should maybe about 30% of the volume of the replacement. But the important technique that which we can follow easily is to subtract from the axial length 2 millimeters and use it as the implant diameter. In addition, for evisceration, we can subtract another 1 millimeter or and again 1 millimeter for hyperopia because you're going to tighten the muscles. So ideally in an enucleation, you can do axial length minus 2 millimeters, and for an evisceration, you can do axial length minus 4 millimeters. If you don't have a proper, or you have a very thysical eye, then maybe you can do an axial length of the normal eye and then try to match the other eye, because our main purpose is to have symmetry between the two eyes. So different techniques which Dr. Vikas has already mentioned and discussed. So here you can see that implant can be of different sizes, and if it is a smaller implant, you'll have to have a larger process, and this becomes very heavy and eventually it will displace downwards. So about sizing the implant, it is very clear about what size and how do we calculate the size. Now where to implant? Ideally, we'd like to implant it in the posterior tenon space. That is, once we remove the optic nerve, we want to get inside and put it in the posterior tenon space, because that is the place where it is least likely to displace. If possible, one can always use a small implant placing instruments, which we can use to put the implant deep inside. In evisceration, it's pretty easy because you're going to put it inside the scleral cup, so it is not a problem at all. So in conclusion, if there is a staphyloma, possibly we would like to do an evisceration with a PMM implant. If there is a thysis bulbi, then we would like to do a modified evisceration, that is a 4-petal evisceration with PMM implants. Enucleation, we can consider porous implant if you're going to plan for pegging, but if you're not planning for pegging, then best is to go for a PMM implant. Now for enucleation, for tumors, ideally we would like to go for a PMM implant because we are never going to plan for a pegging. And if it's an irradiated socket or a difficult socket, you can always think of doing a dermis fat graft. Thank you.